Hello, dear friends. This is psychiatrist Alexander Anatolievich Roshchin with you. Today we will talk about the drug Phenibut. In terms of chemical structure, Phenibut is GABA, gamma-aminobutyric acid. But we know that GABA poorly penetrates the blood-brain barrier. For example, we were able to confirm this by examining the drug aminalone, which is also GABA, just GABA. And naturally it does not penetrate the blood-brain barrier and therefore has low effectiveness. Understanding this fact raised the question of what to do with the molecule to make it penetrate the blood-brain barrier more easily, and various combinations began to be made, such as hopanthenic acid, which is GABA plus pantothenic acid, or for example picamilone, which is GABA plus nicotinic acid, and Phenibut is GABA plus a phenyl ring. So what do we have in these drugs? We have GABA, which will determine the main effects of the drug. This is the most important thing. We have some addition to gamma-aminobutyric acid, which allows GABA to pass through the blood-brain barrier, increasing its availability to brain cells. And depending on what this conductor is, it naturally also determines some of its own effects. Therefore, we then get GABA plus some additional effects of the conductor. What are the effects of Phenibut due to? They are due to its mechanism of action. And if we talk about the nootropic effect, it is realized because gamma-aminobutyric acid can enter the Krebs cycle through the GABA shunt, and thereby increase the energy value of the substrate being used. That is, it becomes more advantageous as a substrate than glucose. That is, more energy is produced. And when there is a condition of ischemic deficiency, which is observed as a result of atherosclerosis, and after injuries and after any other processes, when the balance of energy delivery to the neuron and energy expenditure in the neuron is disturbed, this imbalance can be corrected by increasing energy production thanks to such products as GABA. Naturally, because of this, it exhibits its nootropic effect. And the second point, Phenibut directly affects GABA receptors. And because of this, its tranquilizing anxiolytic effect is realized. So the drug has two effects. One is nootropic and the second is an anti-anxiety effect. What do these effects look like? As for the nootropic effect, motor skills improve, dizziness decreases, performance improves, anxiety decreases. I am not mistaken. This is not an anti-anxiety effect per se. It is an effect derived from the nootropic one. And note here, if anxiety decreases at low doses of Phenibut, it indicates that the drug has shown its effect not because the anti-anxiety effect has already worked, but because thanks to the nootropic action, the manifestations of organic issues have decreased. This means the patient had anxiety of organic origin, and due to the improvement of energy metabolism in brain cells, the organic manifestations decreased and the manifestations of organic anxiety decreased. This is very important because there are quite a few such patients who have an anti-anxiety effect at low doses precisely due to this nootropic impact, due to the improvement of energy metabolism. Furthermore, akathisia may decrease. As for the pure anxiolytic effect, when GABA directly acts on anxiety and when it directly affects, the anti-anxiety effect is determined by the impact on GABA receptors. We can note that the effect of such a drug is not always present. And it's a lottery. Some patients have this effect, while for others the effect may even be the opposite, possibly causing excitement. It might be that the medication doesn't come but suppresses emotions. That is, this anti-anxiety effect is very individual and doesn't occur in everyone. Therefore, when we prescribe this medication, we cannot be sure, for example, as we are with benzodiazepines. We are almost 90% sure that they will have their anti-anxiety effect. But with Phenibut, it's not like that. With Phenibut, it's a bit of a guessing game, as they say. So what are the indications for the patient in this regard? Of course, it's asthenia, it's vasovegetative symptoms, it's clear why it affects these symptoms, it's emotional lability, it's irritability. These are also symptoms characteristic of some organic manifestations, emotional disorders. It's an anxiety state of organic origin. The medication is also used when discontinuing many medications. Thanks to cross-titration, that is, one medication the patient was using is replaced with Phenibut, and then Phenibut is discontinued. This is how benzodiazepines are discontinued, and this is how pregabalin can be discontinued. So, in this respect, it's a medication you can switch to and ease withdrawal syndrome. Then there's the enhancement of the activity of other anti-anxiety medications. Tolerance. Unfortunately, this medication also has this drawback. Tolerance develops with it too. This tolerance develops over the course of a month. And if within a month you haven't achieved a therapeutic effect for the patient, increasing the doses further is pointless. It's not dose-dependent tolerance. For example, with benzodiazepines, tolerance drops by 50% and then stabilizes. It doesn't drop any lower. But if we're talking about Phenibut, it drops to zero. The medication becomes completely ineffective, especially if we're talking about the anti-anxiety effect. And then you need to wait at least a few weeks for it to recover to some extent. But sometimes even a few weeks aren't enough for recovery, for the medication to become effective again. And that's why in the past, all protocols involved prescribing such medications in courses several times a year, for example, every 6 months, because everyone understood that there is tolerance with this medication, and after 6 months, let's say, sensitivity to the medication would be restored and it could be taken again. Side effects. The first is aggressive impact on the gastrointestinal tract lining. Why? Because it's an acid. And naturally, as an acid, it causes irritating effects on the mucous membrane. Therefore, it's undesirable to use the medication in people whose gastrointestinal tract is compromised without acute necessity. For example, those with peptic ulcer disease, gastritis, or other gastrointestinal diseases. Next, how to protect oneself. And here some patients make a key mistake, patients and some colleagues. When they try to protect themselves with things like antacids or milk, that is some alkaline drinks, thinking that this way they compensate for the acidity. But the acidity is not due to the medication increasing the acidity of the gastrointestinal tract, but because the medication itself is an acid. And thus, if you take Phenibut with milk, what will you get? You will get the inactivation of Phenibut's effect. Therefore, if you want to protect yourself, if we want to somehow compensatorily reduce stomach acidity, then it's better to use proton pump inhibitors. Well, the simplest thing would be to just not take Phenibut on an empty stomach. Next, its second important drawback is hepatotoxicity. This should be remembered. It is considered that the medication becomes hepatotoxic at high doses from 7 to 14 milligrams, somewhere in these ranges. But what is meant by hepatotoxicity at such doses? It's the hepatotoxicity when we clearly see the hepatotoxic effect, when we then see liver failure with all the ensuing consequences. But at lower doses, we can see an increase in transaminases. And now there's a tricky position that an increase in transaminases doesn't always indicate that the drug is hepatotoxic. There are entire groups of drugs that cause a persistent increase in transaminases, which are recommended to be overlooked. I have a slightly different position. It's not worth overlooking an increase in transaminases. I have repeatedly encountered this overlooking of supposedly harmless transaminase increases, which over 6 months to a year of taking the drugs could lead to the development of fibrosis and to a high degree. But thank goodness the drug is not effective for long, only a month, so we are unlikely to notice any obvious severe liver damage, but nevertheless, any liver damage is undesirable. And therefore my approach is this. If we are taking Phenibut, we should ideally recommend the patient to take liver function tests after a week, for example. It's not necessary to take them all the time, just check what's happening with the transaminases. If we see any trend towards an increase in transaminases, especially if they exceed the limits, regardless of whether they are increased by multiples or by some percentage, I would not recommend the patient to continue taking this drug. Next, what is a good feature of Phenibut? It has a very wide therapeutic window, so the risk of overdosing on this drug is very minimal. Some people take this drug in grams. We observe the therapeutic effect at doses of about 250 milligrams 3 times a day. If we want to achieve an directly anti-anxiety effect and not an indirect one, then we need doses of 500 milligrams. And it's very rare to see this effect at 500 milligrams. Better at 750 milligrams 3 times a day. That is, the doses need to be large because at smaller doses the brain will, so to speak, consume this drug. It consumes it, uses it as a nootropic, as food, as an element of the Krebs cycle. It is insufficient for the drug to start acting as a neurotransmitter, to start affecting the GABA receptors. Therefore, the doses must be adequate. And also what needs to be noted is that even at doses of 750 milligrams 3 times a day, patients do not always experience an anti-anxiety effect. And I have repeatedly observed cases where there is, on the contrary, an exacerbation of anxiety because there is a stimulating effect, a nootropic effect, and it activates certain mechanisms that lead to the patient's agitation. Therefore, as they say, you have to really guess whether we will get this anti-anxiety effect in the patient or not. The duration of the course, if we do get the expected effect, should be from 3 weeks to 1.5 months. Well, a month is better, as we have already talked about its tolerance. Combinations. The drug is very good for various combinations. In combination with other drugs, we can enhance their effect, significantly enhance the effect. Well, for example, we use gabapentin, and we see that it is slightly underperforming. We can add the same Phenibut. And in principle, with many other drugs, the drug also combines well, even with other GABA drugs. Furthermore, it allows, if necessary, to reduce the dose of other drugs, and for example, with gabapentin, sometimes adding Phenibut allows the dose to be halved. When is this good for us? It's good when we are planning, for example, to discontinue pregabalin. And reducing the dose gives us an exacerbation of symptoms. So we can add Phenibut and calmly reduce the doses. And then, under the cover of Phenibut, we can gradually completely withdraw from one drug or another, in particular from pregabalin or benzodiazepines. That's all I have briefly on Phenibut. Thank you for your attention. All the best to you.